This is a 46-year-old woman who was diagnosed with a stage 3C melanoma now about a year ago, initially with a deep ulcerated primary and multiple involved lymph nodes. She underwent wide local excision and completion lymph node dissection and appeared to be clear of disease. Her choice was not to pursue adjuvant therapy after surgery, and unfortunately, approximately 6 months after completion surgery, she had the development of abdominal pain, and subsequent imaging showed multiple masses in the liver at more than 1 centimeter, scattered pulmonary nodules, as well as some enlarged lymph nodes, thus showing signs of stage 4 metastatic disease. She underwent a tumor biopsy, which did document melanoma, and mutational analysis showed BRAF V600E mutation being present. The question then is what to do going forward. This patient elected to start on BRAF and MEK inhibition with dabrafenib and trametinib. Management of patients with stage 3 melanoma is really undergoing a paradigm shift. I think all doctors agree, and the NCCN recommends intermittent follow-up and consideration of radiologic imaging to assess for recurrence of disease. So generally speaking, that's on the order of every 3 to 6 months or so. The question of what to do in the adjuvant space in terms of treatment is quite fraught. So historically, interferon alpha was considered a standard of care, though the overall survival benefit of that therapy was quite modest. Therefore, and a lot of doctors really advocated for observation only for patients even with stage 3 melanoma. We now know, based on the EORTC 071 data, that there's an advantage in terms of overall survival for ipilimumab at 10 milligrams per kilogram in the adjuvant space. That is also controversial, however, given the high toxicity profile of ipilimumab. And then there's an evolving paradigm of clinical trials that we'll be reporting out in the next few years, looking at BRAF inhibitors, looking at PD-1 antibodies, even looking at the combination of ipilimumab and nivolumab in the adjuvant setting. So this is a wide open space that's subject to a lot of physician discretion, but generally speaking, we see patients at least every 3 months, and we consider whether or not to give them ipilimumab or interferon. Patients who appear to have symptoms consistent with a recurrence or radiologic imaging that suggest a recurrence of melanoma really should be thoroughly worked up. And I would advocate that unless the recurrence is in the exact site of where the primary lesion was or in the exact lymph node basin where lymph nodes were resected, really a biopsy should be pursued. And in melanoma now, the standard of care really should be a core needle biopsy, because we need that tissue then to do subsequent analyses. Most importantly would be mutational analysis. So assessing for the presence or absence of a V600 BRAF mutation is really an essential part of the care of all patients with melanoma. There's even evolving data suggesting we should also be testing for NRAS mutation, with drugs being developed in that space. And then further, there's a debate about whether or not we should be testing patients' tumors for PDL1, programmed death ligand 1, to direct immunotherapy treatments. That's controversial, but it does, again, emphasizes the need to get a good quality biopsy to better direct the subsequent workup. Once that's in place and you have adequate immunohistochemical stains and histologies that prove a diagnosis of melanoma, then move on to consideration of therapy, whether it be local therapy in terms of surgery or radiation, or more likely a systemic approach, again, targeted therapies towards BRAF or immunotherapies.